Like all synovial joints, the knee has two opposing functions: to allow motion between bones and to maintain their articulating surfaces in apposition. The knee joint is the articulation between femur and tibia, the largest bones in the body. In addition to having two condyles for articulation with the tibia, the femur has a patellar surface for articulation with the patella. There is a sharply angled medial and a tapering lateral articular surface. The patella is in the quadriceps tendon. It inserts by the patellar ligament into the tibial tubercle. It articulates in all positions with the femur and provides leverage for the quadriceps. Each femoral condyle has a tibial surface for articulation with a tibial condyle. The lateral condyle has less articular surface than the medial. The two are separated by a large intercondylar fossa. Above the condyles are the epicondyles, medial and lateral. Note the eccentric position, an important feature for understanding function of ligaments which attach here. The tibia presents a flattened upper articular surface. As in the femur, the medial condyle has more surface than the lateral. Between the condyles is an anterior intercondylar area and a posterior intercondylar area, separated by an intercondylar eminence. There are two tubercles on the eminence, but nothing attaches to them. A study of the dried bones alone introduces certain features of knee motion. Movement is primarily flexion and extension. On approaching full extension, the end of the articulating surface of the smaller lateral condyle is reached, while some articulating surface on the medial condyle remains. To finish its motion, the femur is rotated medially on the tibia. To begin extension, the femur first rotates laterally. The motion is being exaggerated here, but the femoral rotation is easily palpated in the living. Two structures which lie on the articular surface of the tibia are the discs or menisci, one on each articular condyle. The meniscus is a fibrocartilaginous structure. The lateral meniscus is smaller, rounder, looser, and its two ends are attached to the intercondylar eminence. The medial meniscus is larger but narrow, more open or C-shaped, more firmly attached, and its ends attach in the intercondylar spaces. The disc is attached peripherally by the capsule to the tibia. The portion of the capsule which attaches disc to tibia forms an incomplete crown around the tibia and so is called the coronary ligament. The meniscus is thicker peripherally and tapers to a thin edge centrally. The transverse ligament of the knee attaches the discs anteriorly. It is absent in this specimen, but present here. Menisci vary in shape. They may even be hollow discs. On this right knee, motion shows that discs are attached loosely to the tibia and move with it in flexion and extension. There is an attachment of the lateral meniscus to the femur by the posterior meniscofemoral ligament. Occasionally, this ligament has an anterior slip. Synovial joints have three major means of maintaining joint stability. One of these is by muscle. This film shows only the joint. It is assumed that muscles of the thigh and leg have been studied. Those muscles which produce motion at the knee are also powerful stabilizers. They regulate joint movement and joint position and may resist powerful external forces. For the athlete, one of the safeguards against joint injury is muscle exercise. A second means is by ligaments. We will identify the capsule and two pair of ligaments. The fibrous capsule is a joint ligament. It ensheathes the joint. It attaches to tibia and close to the condylar margin of the femur. It has several reinforcements. Anteriorly, it attaches to patella, quadriceps tendon, and patellar tendon. These three structures replace the capsule anteriorly. Posteriorly, the capsule attaches to tibia and femur. And here is reinforced by these oblique fibers from the semimembranosus muscle, the oblique popliteal ligament. It has already been noted that the inferior portion of the capsule attaching menisci to the tibia is called the coronary ligament. It is expected that a hinged joint will have collateral ligaments. At the knee, the two collateral ligaments are named for their inferior attachment. The tibial collateral blends with the capsule. The fibular collateral can be dissected free from the capsule. On the right knee, the capsule has been dissected away. The tibial collateral ligament is flattened, runs from tibia to medial epicondyle, blends with the capsule, and through the capsule attaches to the medial meniscus. The fibular collateral is rounded and cord-like. It is separate from the capsule. This is the tendon of the popliteus muscle running deep to the ligament to enter the joint capsule. Collateral ligaments resist abduction or adduction, but permit flexion and extension. Because of their eccentric attachments, the collateral ligaments become taut on extension and resist hyperextension. In addition to the two external ligaments, there are two powerful internal ligaments which add greatly to joint stability. The two ligaments cross each other like an X and are called cruciate ligaments. Each is named specifically for its tibial attachment. The anterior cruciate ligament attaches to the anterior tibial intercondylar space. It inserts on the lateral femoral condyle. The anterior cruciate ligament prevents anterior displacement of the tibia. The posterior cruciate ligament attaches to the posterior tibial intercondylar space and inserts on the medial femoral condyle. The posterior cruciate prevents the tibia sliding posteriorly. The third means of maintaining joint position is by bone morphology. Compared with the acetabulum, into which the femoral head fits, the tibia appears flat. The tibial condyles do, however, have a depression. These are deepened by the menisci. Because of the intercondylar eminence, lateral motion of the femur involves separation from the tibia. Such an action is resisted by strong ligaments. Joint mobility is provided by lubricating articulating surfaces of smooth hyaline cartilage. Cartilage is smooth, resilient, avascular, and without nerves, all admirable properties for a joint surface. Synovial fluid lubricates these slippery surfaces. Synovial fluid is produced by the synovial membrane. The membrane lines the fibrous capsule in only a general way. Its extent and shape may be more easily understood if one thinks of three pair of articulating surfaces which communicate. The joint between patella and femur is continuous with the condylar joints. It extends superiorly to joint a bursa between quadriceps tendon and femur, the suprapatellar bursa. Think of the two condylar joints as though partitioned by a membrane which houses the cruciate ligaments. The membrane breaks down anteriorly, passes around the cruciate ligaments, and excludes them from the synovial cavity. If fluid must be withdrawn or medication introduced into the joint, the bursa provides a relatively safe route. There is no synovial membrane on articular surfaces of condyles, patella, or menisci. The space between tibia, femur, and patellar tendon is filled by the infrapatellar fat pad. It is lined by synovial membrane and is attached to the femur by the infrapatellar synovial fold. There are other lubricating mechanisms or bursae around the knee. For example, skin moves on patella. This is part of the prepatellar bursa. Between patellar ligament and tibia is the infrapatellar bursa. There are suprapatellar, prepatellar, and infrapatellar bursae. Some bursae, which lubricate tendons, also communicate with the knee joint. For example, the bursa for the medial head of the gastrocnemius. The bursa for semimembranosus. In motion, then, the lubricated joint surfaces of smooth hyaline cartilage act like a hinge with some rolling and sliding. At full extension, the femur rotates medially. The joint is said to be locked. Most ligaments become taut in this position, the most stable for the knee, and muscles relax. In flexion, ligaments are slack. Some rotation is then possible. Knee injuries are common. Inflammation of the prepatellar bursa is called housemaid's knee. Collateral ligaments resist abduction and adduction. A strong force to the lateral knee may strain or rupture the medial collateral ligament. The meniscus moves with the tibia. On heavy weight bearing with the knee in flexion, strong lateral rotation might tear a meniscus between femur and tibia, usually the medial meniscus, because it is more firmly attached. Trauma may rupture a cruciate ligament. Rupture of the anterior cruciate permits anterior displacement of the tibia. Antero-posterior motion, called the drawer sign, is pronounced when both cruciate ligaments are severed.